Academy of Pediatrics. And thanks to WBAP as a whole for giving us this opportunity, a platform to our youngsters, and thanks to the digital media which has made it possible. So, without wasting any more time, let's start straightway. We have 5 speakers, 5 presentations, and have been mentored by 2 dynamic mentors, Dr. Nupur Ganguly and Dr. Dr. Nupur Bajpai and Dr. Somnath Ganguly. They are wonderful senior residents. And so under their guidance, I request Dr. Arnab Rai to start with the first presentation, Trader Meets Pickwick. Arnab, you start, please.
Thank you, ma'am. Thank you, my respected
teachers. A bit louder.
Thank you, my respected teachers and my mentors. Myself, Dr. Arnab Rai, first year PGT, Department of Pediatrics, NBMCH. Thank you for providing me this opportunity to speak in front of you on my case under the heading Trader Meets Pickwick. My case was an 8-year-old male child residing in Siliguri. He was admitted with chief complaints of difficulty to breathe for last 2 weeks. This difficulty to breathe was insidious in onset. It was associated with snoring while sleeping, with intermittent stoppage of breathing for a brief period of time, waking him up from sleep, causing daytime sleepiness. There was no history of fever, cough, no expectoration, no palpitation, no bluish discoloration of fingers and lips. On further probing, similar kind of distress was present for last couple of years. It was on and off and was never severe enough to necessitate hospitalization. As the child was morbidly obese, the mother was inquired further to reveal that there has been abnormal increase in appetite since 2 years of age, causing excessive intake of food and excessive weight gain. Parents sought medical attention and were advised to control his diet and increase his physical activity. Coming to history of past illness, he was operated at 1.5 years of age for empty scrotal sacs. His birth history, antenatal history was uneventful. He was born at term. In the mode of delivery was emergency elusius due to meconium stent liquor and fetal distress. He was born with birth weight of 2.5 kg. He did not cry at birth. He has to be resuscitated and admitted in NICU. He was discharged 14 days later after breastfeeding was initiated. Coming to feeding history, the child had to be readmitted after 1 month due to weight loss and inability to feed. He was discharged 7 days later with OG tube in situ. The child had to be fed with OG tube till 1 year of age. At around 2 years of age, his feeding ability and appetite gradually increased, and he started eating voraciously. Now he eats excessive amount of food, even resorting to stealing. That's why it has been difficult for us to calculate protein and calorie intake by 24-hour recall method, as the child eats all the time and even without knowledge of his mother. The child is immunized till death. Coming to developmental history, he had developmental delay in all 4 domains, though hearing and vision were normal. There are no history of obesity in the family, no history of diabetes or thyroid disorder. Both his parents are normal build. His one elder sibling is also normal build. He belongs to a lower socioeconomic class according to modified Sukubu-Sami scale. Coming to general examination and head-to-toe examination, his BP was normal, though his respiratory rate was slightly higher at 28 per minute, and saturation was 93% with 2 liter oxygen with nasal prong. The child is morbidly obese. There is a hump over the nape of his neck. There were multiple stria over the flanks of the abdomen and inner thigh. There is no hyperpigmentation, though. His penis is buried deep into the fat with the small penis. Coming to his anthropometry, his height was 128 centimeter, weight 75 kg, BMI of 45.7 kg per meter square. His weight for age more than 97th percentile, making him overweight, and height for age was normal. As for the BMI, his BMI was so great that we could not even plot it in the IAP provided chart. Coming to examination of the respiratory system, in upper respiratory tract, we did not find any DNS, nasal polyp, or nasopharyngeal mass. His both tonsils were normal. Lower respiratory tract was also normal. His cardiovascular system was also normal. On examination of GI system, there were multiple stria in bilateral flanks, and deep palpation could not be done due to excessive belly fat. On examination of genitourinary system, both testes were not palpable in the scrotum or even in inguinal canal. His neurological examination revealed no abnormalities. So my case summary from history and clinical examination was 8-year-old male child from Shiliguri, born to non-consanguineous marriage at term, with perinatal asphyxia, empty scrotum, feeding difficulty, and developmental delay. In early years of life, developing excessive appetite from around 2 years of life, causing morbid obesity. Now presence with respiratory distress with snoring and recurrent history of waking from sleep at night, causing daytime sleepiness without any respiratory or cardiovascular cause, probably due to obstructive sleep apnea. Key points that we found from history were developmental delay, feeding difficulty followed by excessive eating, respiratory distress, snoring, daytime sleepiness. And from examination, the child was morbidly obese, there were empty scrotum, small penis, and we did not find any respiratory cause or cardiovascular cause. So it was already evident that the cause of obesity was not constitutional, but some other hormonal or genetic causes were at fault. Hormonal causes could have been hypothyroidism, Cushing's, pseudohypoparathyroidism, pituitary adenoma, and genetic causes were Prader-Willi, Lawrence-Boone Bardet-Biedl, or melanocortin 4 receptor mutation. Keeping in mind these differential diagnoses, we proceeded further. On basic investigation, his CBC was normal, LFT was also normal, urea and creatinine were also normal. His lipid profile was also normal. His fasting blood glucose and HbA1c was also normal. His TSH and free T4 level was also within normal limit. 8 AM cortisol level was also within normal limit. CTH was also normal and PTH was also normal. We then did a chest X-ray and it was normal. We also did 2D echo and it came out to be normal. USG whole abdomen revealed both testes in inguinal fossa. We then did an MRI of the brain to rule out any pituitary causes of obesity and did not find any. And at last, our genetic study report came and was stamped. The child was stamped as Prader-Willi syndrome. Coming to the cause of respiratory distress, we did an ABG at daytime, and we found that his PSCO2 was significantly higher at 65 millimeter mercury. And as it was associated with morbid obesity, obstructive sleep apnea, and absence of other causes of respiratory distress, our diagnosis was Pickwickian syndrome. Post during hospital stay, he was given moist oxygen and intermittent CPAP. He was given dietary advice and he was advised to increase his exercise. His symptoms improved gradually and he was discharged with CPAP at home. Some words about Pickwickian syndrome. It is also called obesity hypoventilation syndrome. It is characterized by awake alveolar hypoventilation and daytime hypercapnia, diminished ventilatory drive and capacity related to obesity. It is a diagnosis of exclusion in absence of any respiratory, neuromuscular, or metabolic explanation of hypoventilation. Take home messages is that with increasing prevalence of obesity, Genetic causes of obesity should also be kept in our mind besides just constitutional and hormonal causes. The prevalence of OHS is also on the rise. It often remains undiagnosed until late in the disease. It is commonly misdiagnosed, resulting in frequent hospitalization. Early diagnosis is essential as this patient has significant morbidity and mortality, and also the impact of therapy on complications and mortality is positive. Thank you. Now I'd like to invite Dr. Prashanjit Burman to present his case. Thank you.
Good afternoon, everyone. Myself, Dr. Prashanjit Burman, PGT, Department of Pediatrics, North Bengal
Yes,
Medical College.
Prasenjit, please,
Yes, ma'am.
thank you. Thank you for your patient hearing. Our intention of presenting this Ornob's case was Prader-Willi, it was from the beginning. All the clinical features and morphological features were like that of Prader-Willi. But we wanted to highlight the cause of his respiratory distress, that is Picquickin syndrome. It has been described based on that the novel obese character in Dickens' novel who was having respiratory distress. And so how to diagnose that, and ideally sleep studies could delineate it further, but due to lack of facilities, we could not do the sleep studies. But we should remember that we should keep in mind this uncommon Picquickin syndrome also in any cause of obesity. Thank you. If you have any comments, you can write. What surgery was done, Dr. Arun Mangli? Thank you, sir, for asking this. What surgery was done at 18 months of age? Actually, we are not sure what surgery was done because the child presented to us at 8 years of age, and his scrotal sac was empty, and both the testes were found on ultrasonography in the inguinal canal. So we are not very much sure. And next, I would request Dr. Prasenjit Burman. His presentation is common brain, uncommon bug. So let's see what uncommon bug he is talking of. We can start, Prasenjit, now.
Thank you, madam. Thanks for giving me the opportunity to discuss a case with you of acute meningoencephalitis under the heading common brain, uncommon bug. My case was a 10-month-old boy who presented with low-grade intermittent fever for 1 week, cough for 1 week, multiple episodes of GTCS for 2 days, irritability with abnormal behavior for 2 days. There was no history of rash, petechiae, purpura, no history of ear discharge, no loose stools, no history of decreased movement of any of the limb, no history of TB contact, no history of poisoning or any drug overdose. There was no previous history of any hospitalization or blood transfusion in this child. Birth history of the child was within normal limit. There was no history of any developmental delay in all 4 domains. The child was immunized as per national immunization schedule, and last vaccine was taken MR at 9 months of age. BCG scar was present in left upper arm. No family history of seizure disorder was there. There was no consanguinity. The child belongs to a lower middle class family engaged in cultivation. The weight of the child was 10 kgs, length was 70 centimeters, head circumference was 46 centimeters, and mid upper arm circumference was 14 centimeters. There was no wasting or stunting. Faces of the child was normal, and on general examination, the vitals of the child was within normal limit. There was no pallor, edema, icterus, cyanosis, no neck vein was there, and there was no lymphadenopathy. With this, I went for examination of the central nervous system. The GCS of the child was 12 by 15. The child was irritable, anterior fontanelle was bulged, tone was increased, DTR was exaggerated, power was 5 by 5 in all the 4 limbs. No neck rigidity was there, carnic and Buzinski signs were absent, and cranial nerve examinations were within normal limits. Examination of the other system, including CVS, respiratory, and GIT, was within normal limit. So, a 10 months old, fully immunized, developmentally well, otherwise normal child presented with acute onset of fever with multiple episodes of GTCS for the first time in his life, with altered behavior and irritability, with increased tone and exaggerated DTR, while examination of the other systems revealed no abnormality. This suggests this might be a case of acute meningoencephalitis. So with this history and clinical background, I investigated the child, and his blood reports and his blood parameters were within normal limit except for CRP, which was markedly raised, and there was neutrophilic leukocytosis, and there was mild hyponatremia, and calcium was within normal limit. Tuberculosis skin test was negative, MPDA typhi dot was negative, IgM for dengue, JE scrap typhus was negative, HIV of parents was negative, urine RE MECS revealed no abnormality, and chest X-ray was within normal limit. As a part of investigation, I did CSF in this patient, and the physical appearance of the CSF was cloudy with total cell count of 1500 per cubic millimeter. Protein was 86 milligram per deciliter. CSF and blood sugar ratio was less than 0.4. Gram staining of CSF showed gram-positive cocci. HSV DNA PCR was negative, and no fungi was detected on KOH mount and India ink stain. As a part of investigation, I also did imaging in this child, which revealed features of MRI brain, non-contrast MRI brain in this child revealed features of acute encephalitis with bilateral subdural diffusion. So I started on treatment treatment started as a case of acute meningoencephalitis in this child with all supportive measures, and blood culture and sensitive AST sample was sent to the Department of Microbiology in BMCH. The child in follow-up EEG and BERA was performed in this child. EEG was within normal limit, and BERA showed bilateral severe to profound hearing loss. The story would have ended here, but it did not. Later, the blood culture report came, and it revealed an unusual organism called Staph pseudointermedius via Vitek 2 with 94% probability. As this was a very unusual organism to be found on blood culture and especially causing CNS infection, I approached to the Department of Microbiology in BMCH to gather more information about the organism. Now, who is Staph pseudointermedius? Staph pseudointermedius was first described in 2005. It is a gram-positive cocci and non-motile, non-spore forming facultative anaerobe. It is a commensal of skin and mucous membrane of pets and domestic animals, especially canines. It was isolated from the skin of mucous membrane of healthy canine between 20 to 90%. The number is quite significant. Morphologically, it appears as grape-like clusters, but can also be seen as individual or paired cocci. Staph pseudointermedius in humans spread mainly via exposure to canines or domestic animals. It is known to cause various infections such as bacteremia, brain abscess, pneumonia, ear infection, leg ulcer, wound infections. Here you can see the creamy white colonies of Staph pseudointermedius with beta hemolysis on blood agar. And these are the virulence factors of Staph pseudointermedius with different enzymes, secreted toxins, enterotoxins, etc. These are the biochemical reactions that Staph pseudointermedius causes. As this was an unusual organism causing human infection, so I searched for literatures on Staph pseudointermedius, finding total of 339 publications, including Public Health Agency information like National Institute of Health, CDC, the European Center for Disease Prevention and Control, the US FDA, Agency for Healthcare Research and Quality, etc. Literature is published, including research articles, review articles, and case reports were gone through, which revealed that staph pseudointermediates has now becoming a concern in humans because of its close similarities to human pathogens staph intermediates group. The SIG, that is staph intermediates group, includes staph intermediates, staph pseudointermediates, and staph delphini, is becoming a matter of concern as these are not only human pathogens but also have all the properties which a multi-drug resistant staph aureus possesses. Reports suggest that staph pseudointermediates is a normal flora in canines and cattle, colonizing the mouth, nose, perineum, and groin. The transmission is vertical in canine, but horizontal or interspecies in case of humans via close contact with colonized pet. Risk factors in humans include immunocompromised state, post-surgical infections, old age, etc. No human-to-human transmission is still reported. And these are the diseases caused by staph pseudointermediates, ranging from skin and soft tissue infection to endocarditis. These are the publications which are available on the internet on staph pseudointermediates causing human infections and its multi-drug resistance. Wall map showing countries reported human infections caused by staph pseudointermediates. So what are the learning points in my case? After obtaining the blood culture report, we inquired about exposure of the child to pets or any domestic animal. There was a positive history of the child playing with pet dog and having cattle in the house. So we should not eliminate the uncommon organism causing CNS infection until the identification of the pathogen is completed. There are very few cases of staph pseudointermediates causing diseases in children, especially CNS infection. In my case, the boy was an infant and also had the positive history of close contact with pet dog. Maybe this was the reason, that's why he got infected by staph pseudointermediates. Lastly, all this data show that staph pseudointermediates is an emerging pathogen and its multi-drug resistance is obviously a matter of concern. Thank you for your patience, and then I invite my next presenter, Dr. Shobhi Kumar Modi.
Thank you, Dr. Prasenjit. I can't see any new question or comment related to this case on the chat box or neither in the question and answer section. So actually, our intention of presenting this case is that whenever we get a child with meningitis and all, we should also take history of, frankly speaking, we didn't take that history of contact with cattle or dog. So if there is a kind of contact with cattle or dog, we came to know for the first time that there's one new entrant in this staph group is Staphylococcus pseudointermediates, and we should be keeping that in mind. So there is a question, what is the drug of choice? Prasenjit, if you can answer this question.
Actually, staph pseudointermediates acts like staph aureus, and it's it may be MRSA. In our case, most of the medicine, most of the antibiotics the organism was resistant to most of the organisms, but it was intermediately sensitive to vancomycin and gentamicin and tetracyclines.
So there is another question, treatment, madam. So I think that has also been covered. So if there are no more comments or questions, let's move on to the next one. And next one is I would like to invite Dr. Shovik Mullik, and he will in short describe two cases which will the message being that we have to look beyond the obvious. So Shovik, you can start now.
Thank you, madam.
And speakers, please speak a little louder. All your voices are coming very as if from a very distant. Speak a little louder. Thank you. Start.
Thank you, madam. Very good afternoon to respected ma'am, sir, my seniors and my juniors. At the outset, I am grateful to the organizers for giving me an opportunity to present before you not one but two interesting cases titled Looking Beyond the Obvious. In case one, we have an 11-year-old girl child from Mathabhanga who presented with intermittent fever for 20 days, multiple peripheral joint pain for 15 days, a rash over the face and the bridge of the nose, and generalized headache for 15 days, and generalized weakness for 10 days. On further elaboration, the fever was insidious in onset for 20 days, was low grade, was intermittent in nature, was not associated with chill and rigor, diurnal variation, night sweats, cough, sore throat, ear discharge, pain abdomen, vomiting, diarrhea, burning sensation during micturition, and abnormal movements. There was no history of TB contact. Multiple peripheral joint pain for 15 days initially started with the involvement of the bilateral elbow joint and the knee joint, and then to the small joints of the hands, especially the metacarpopharyngeal joint. Was associated with some restriction of physical activities and weakness, but was not associated with joint swelling and morning stiffness. A rash, as shown in the picture, was present over the face and the bridge of the nose for 15 days, was erythematous and non-itchy, and was photosensitive. The headache was persistent and generalized, dilating for 15 days, and was not associated with photophobia, nasal discharge, or ear discharge. Generalized weakness for 10 days, and it was gradually progressive in nature. She did not have any major illness in the past. Her parents and her 4 siblings are healthy. She is immunized as per NIS, is not non-vegetarian by choice. She received paracetamol and coampicillin before hospitalization, and she has yet not attained menarche. Coming to the general survey, an erythematous rash was present on the face and the bridge of the nose, spraying the nasolabial folds. Moderate degree pallor was present. Icterial sinuses, clubbing, and edema was not present. Neck veins were not engorged. Lymph nodes were not palpable. A reddish ulcer seen in the picture was present with the hard palate, and it was non-tender. Pulse, BP, and saturation was within normal limits. Height and weight was within normal limits, and SMA staging was of stage 2. Coming to the systemic examination, we start from the gastrointestinal system. The liver was palpable 4 centimeters below the right prostate margin, and the liver span was 14 centimeters. No other organomegaly, shifting illness was present. IPS was normal. The respiratory system, the cardiovascular system, and the central nervous system was within normal limits. Coming to the case summary, an 11-year-old girl child presented with intermittent fever for 3 weeks, polyarthralgia involving the peripheral big joints and the small joints of the hands for 2 weeks, rash over the face, generalized headache, and generalized weakness for 2 weeks. On examination, moderate degree pallor and erythematous non-itchy macular rash was present over the face and the bridge of the nose, sparing the nasolabial folds, and a non-tender reddish ulcer was present over the hard palate, and non-tender hepatomegaly was present. Coming to differential diagnosis, we suspected immunological cause, that is SLE, and infective cause, as we live in a tropical country, tuberculosis, HIV, viral hepatitis, and malaria. Coming to the workup, the hemoglobin was persistently decreased, total count was persistently decreased, the platelets was within normal limits, CRP was decreased, and ESR was increased. The retic count was also increased. The blood culture showed no growth. The urine routine examination, microscopic examination, the urine PCR was within normal limits. The urine culture showed no growth. CBNAT for sputum, MPMPDA, HBsAg, anti-HCV was negative. HIV1 and HIV2 was non-reactive. We did a liver function test of the patient. SGOT and SGPT was increased. The total protein, albumin, and bilirubin was within normal limits. USG whole abdomen was done, which showed mild hepatomegaly, normal ecotexture, no lymphadenopathy, and no ascites. Chest X-ray was within normal limits. A 2D echo showed left ventricular contraction was good, and ejection fraction was more than 70%. No vegetations were seen. Coming to the key points from the history, she was an 11-year-old female child, fever for 3 weeks, rash for 2 weeks, joint pain, headache for 2 weeks, and weakness for 10 days. Coming to the clinical examination, an erythematous rash was present over the face and the bridge of the nose, sparing the nasolabial folds. A reddish ulcer was seen over the hard palate, and hepatomegaly was present. Coming to the investigations, the hemoglobin was persistently decreased, the total count was persistently decreased, and the liver enzymes, especially the SGOT and SGPT, was persistently increased. On further examination, ANA with Hep2 titer was positive in 1:3 dilution, having a nucleolar speckled cytoplasmic pattern. Anti-TSDNA was positive, anti-U1 RMP was positive, serum C3, C4 was decreased, and direct Coombs test was positive. We further did the following as the SGOT and SGPT was increased, and she had a history of body ache. Creatine phosphokinase was markedly increased, LDH was markedly increased, renal biopsy, EMG, NCV was done, and the reports are pending. So the take-home message from case 1, we suspected this to be a fluid case of SLE. but she had features of SLE as well as myositis. So we had to look beyond SLE, as she had features of SLE and myositis, suggested it to be a case of mixed connective tissue disorder. Coming to case 2, we have a 10-year-old girl child from Siliguri who presented with continuous fever with cough and cold for 7 days, breathlessness for 5 days. On further elaboration, the fever was insidious in onset for 7 days, low grade, was not associated with rash, chill and vigor, vaginal variation, night sweats, sore throat, ear discharge, pain, abdomen, vomiting, diarrhea, burning sensation during micturition, abnormal movement, and joint pain. Was continuous in nature, and there was no history of TB contact. The breathlessness was present for 5 days, insidious in onset, gradually progressive, increased on mild physical activity. Cough for 5 days, was non-productive without any bloody tinge. Heaviness was present in the lower part of the chest of both the sides for 5 days. There was no history of palpitation and chest pain. She had no major past illness. Her parents and the 2 siblings are healthy. She is immunized as per NIS. She is non-vegetarian, and she received paracetamol and coamoxicillin before hospitalization, and she has yet not attained menarche. Coming to the general survey, mild degree pallor was present. Icterus, sinuses, clubbing edema was not present. Neck veins were not engorged. Lymph nodes were not palpable. The pulse, saturation, BP was within normal limits. The height and weight was within normal limits, and SMR staging was of stage 2. Coming to the systemic examination, we start from the respiratory system. The respiratory rate was increased, abdominal thoracic. There was bilateral restricted movement of the lower part of the chest, and there was no subcostal or intercostal suction was present. The trachea was centrally in position. The vocal fragmentus was decreased in the bilateral infrascapular, infraaxillary, and inframammary areas. There was a dull note on percussion. Bilateral vesicular bed sounds was present, but decreased in the aphosae areas. The vocal resonance was decreased in the aphosae areas. The cardiovascular system, the gastrointestinal system, and the central nervous system was within normal limits. Coming to the case summary, a 10-year-old girl child presented with persistent fever and non-productive cough for 7 days, followed by progressive dyspnea and heaviness over the lower part of the chest for 5 days, without any chill and vigor, diurnal variation, night sweats, sore throat, ear discharge, pain, abdomen, burning sensation in micturition. On examination, mild degree pallor was present, tachypnea was present, decreased vocal fragmentus, dull note on percussion, decreased vesicular breath sounds, and vocal resonance in bilateral, infrascapular, infraaxillary, and inframammary areas. The differential diagnosis is suspected was to be a case of bilateral pleural effusion due to pulmonary effusion, pulmonary tuberculosis, autoimmune cause, or a malignant cause. The workup showed hemoglobin was mildly decreased, the total count and the platelets was within normal limits, CRP was within normal limits, ESR was increased. The urine for routine examination, microscopic examination was within normal limits. The urine culture showed no growth. The blood culture showed no growth. LFT was within normal limits. The RFT was within normal limits. And the CBNAT sputum sample, which did not detect any mycobacterium tuberculosis, was not detected. Chest X-ray showed bilateral pleural effusion. A 2D echo was done, which showed mild pericardial effusion. Left ventricular contractility was good, and ejection fraction was more than 70%. The USG chest showed bilateral blood fluid collection. USG whole abdomen was within normal limits. The pleural fluid tap was done, and the study showed it was transitive in nature. So coming to the key points from the history, she was a 10-year-old female child, fever for 10 days, breathlessness for 5 days, bilateral air entry was decreased. Coming to the investigations, chest X-ray showed bilateral pleural effusion, and a 2D echo showed mild pericardial effusion. So how to proceed further? As we ruled out infectious causes as well as systemic causes, we had to look beyond infected as well as systemic causes. ANA was done, which was positive, and 1:320 dilution having coarse spectral pattern. The ANA profile was done, and anti-DSDN was negative, anti-split antibody was positive, C3 and C4 was within normal limits. The direct Coombs test was negative. So as ANA was positive at a titer of 1:80 dilution, we gained entry criteria. Fever was present, pleural effusion and pericardial effusion was present, and anti-split antibody was present, giving a total score of 13, which was more than 10 to classify SLE. So coming to the take-home message, in case 1, we had to look beyond SLE because she had features of SLE as well as myositis. So it was suggestive to be a case of mixed connective tissue disorder. Coming to case 2, she presented with fever and breathlessness, suggestive of infective cause or systemic cause, but we had to look beyond infective and systemic causes as we yet could not arrive to a diagnosis. We came to a diagnosis, we could classify the case to be SLE as a score of more than 10 was achieved. So we had to look beyond the obvious causes. Thank you very much. I would like to call upon my next speaker, Dr. Pingal Roy, to speak on the next case.
Thank you. Thank you, Dr. Shovik. I would like to invite comments or questions. If there are none, we can proceed to the next speaker. Actually, the purpose of this presentation was that the difference between the two cases was, first case was more or less, it was nothing other than SLE, but should not stick our thoughts to SLE only. The clues to where the body ache and then raised CPK, and so it was something in addition to SLE. And for the second case, the child, initially SLE was never in our differential diagnosis. It was respiratory distress, fever, infective cause, but when none of the infective causes were so, then after excluding all other causes, we thought of autoimmune cause. So this is the difference between these two cases. And if there are no comments, is there any? There is good common cases, but look beyond it. Yes, sir. Thank you, sir, Dr. Manglik. Then is there any significance of bill ear problems in the second case? Bilateral ear problem. Was ANCA done to exclude GPA? Dr. Shovik, was ANCA done?
Yes, ma'am. Yes, ma'am.
ANCA was probably negative, isn't
Yes, ma'am.
it?
Yes,
If I am
yes,
not
ma'am.
wrong.
Yes, ma'am.
So ANCA was negative and bilateral ear problem in the second case. Shovik, will you comment on that?
No, ma'am.
There was, have you told that there was bilateral ear problem?
I had pleural effusion. No, yeah.
Pleural effusion. It was
Pleural effusion.
ear
Pleural
problem.
effusion. Pleural effusion.
Yes.
Yes.
So there
Yes.
was bilateral pleural effusion in the second case. So let's proceed to the next case. I would invite Dr. Pingal Rai, who will try to solve some calcium conundrums. You can start, Pingal.
Good afternoon, everyone, present dignitaries and respected teachers. I am Dr. Pingal Rai, second year postgraduate resident at Department of Pediatrics in North Bengal Medical College. Today, I will present not one, but two cases under the heading of solving calcium conundrums. Now, to begin with the presentation, the first case, a 1-year-old girl from Kishanganj, Bihar, firstborn out of a non-consanguineous parentage, presented to us with multiple episodes of convulsions involving all 4 limbs for the last 3 days. Reduced movements of both right upper and lower limbs for the last 3 days. Coming to the history of present illness, the convulsions were generalized, involving all 4 limbs, each episode lasting 15 to 20 minutes, and it was associated with uprolling of eyeballs, frothing from mouth, and followed by loss of consciousness. The paucity of movements in the right side of the body was sudden in onset, involved both upper and lower limbs of the right side simultaneously. Initially, distal limb movements were affected, but gradually proximal limb movements were also involved within the next 12 hours. There were no history of any facial deviation or any involuntary movements. There were no history of any fever, head injury, rash, bleeding spot, gum bleeding, any vomiting, loose stools, or any history of recent vaccination was also absent in this child. There were no past history of similar events or hospitalization in this child. The perinatal history in this child was insignificant as all parameters were within normal limits. The child attained all developmental milestones in all domains appropriately for her age as per age. She was immunized up to date as per national immunization schedule. The family of the child belonged to upper lower class of the modified Kupusomi scale. The child, as I mentioned earlier, is a product of non-consanguineous parentage, and there were no history of any seizure disorder or brain as well in the family. The child was exclusively breastfed for the first 6 months of life, and then complementary feeding was gradually initiated after the 6 months of age. No protein calorie deficit were there. But interestingly, though, the child did not receive any multivitamin or vitamin D supplementation during her infancy period. Coming to the clinical examination proper, the general survey part, the child was obtunded, responsive to sound stimuli, decubitus of choice was supine, anterior frontal was at level, no facial dysmorphism or ear discharge was present. Although the right hand attained a particular peculiar posture as it was flexed at wrist joint, flexed at metacarpophalangeal joints, and extended at interphalangeal joints, as it is very much evident from this picture given along with. The right lower limb of the child was abducted, externally rotated, and plantar flexed. On careful examination, no skin vesicles or any neurocutaneous markers were seen in this child. The vitals were all within normal limits in this child, and the BP measured in all 4 limbs were within 50 to 90th percentile as per her age and length. The anthropometry, as it is very much evident from the charts given along with, that the child was neither stunted nor underweight, and she was not wasted either. But her head circumference for her age was above 97th percentile, so macrocephaly was present in this child. Now coming to the central nervous system examination, her higher mental functions were examined next. Her GCS were E4, V1, M5, and she was responsive to voice. Second, third, fourth, sixth, and seventh cranial nerves were examined in this child, and all of them were within normal limits. Now the motor system were examined. The tone in the right upper and lower limb was diminished, and power was also diminished in the right upper and lower limb in the grade of power 2/5, and the plantar reflex in the both sides were flexor. No other significant abnormalities were found in this child in the motor system examination. The sensory system could not assess properly in this child, but pain and temperature sensation was present in this child, and there was no deficit in that particular area. Meningeal signs and cerebral signs both were absent in this child, and other systems examinations such as cardiovascular, respiratory, gastrointestinal, and lymphoreticular system were all within normal limits, as the findings were insignificant. Now to summarize this case, a female infant with normal birth history and development with no familial history of any seizure disorder presented to us with multiple GTCS resulting in focal neurological deficit. On examination, the sensorium of the child was altered, along with there were right hemiparesis with carpopedal spasm of the right upper limb with hypotonia in right upper and lower limb were also present. The child was normotensive, no meningeal signs were present, and there was an interesting history of receiving no multivitamin or vitamin D supplementation during her infancy period. This particular summary gives us many differential diagnoses. Mainly, first, pediatric stroke comes to our mind. Among them, it can be of ischemic origin or thrombotic or hemorrhagic, or any other stroke mimics can also be present in this child also, such as infective causes, such as meningitis, encephalitis, or any demyelination, any inborn error of metabolism, or any electrolyte abnormalities. So these are the possibilities in this case. Now with this relevant information, we are proceeding towards relevant investigations and imaging. After initial stabilization of the child, CBG measurement and ABG was done, and the ABG interestingly revealed an ionized calcium level of 0.36 millimole per liter, which is very low. So it is a case of a severe symptomatic hypocalcemic child. So initially IV calcium gluconate loading dose was given, but carpopedal spasm was still persisting in this child. So we started the maintenance dose of calcium gluconate, and anti-epileptics were also added. Next, we proceeded to further investigations to determine the pathology behind this presentation. As you can see from the chart given along with, the initial routine investigations revealed the hypocalcemia and hypophosphatemia being present in this child. So the initial reports and the clinical presentation both are pointing towards some calcium or phosphate related disorders being present in this child. With this relevant information, we are proceeded to next stages of investigations to look for the actual disease pathology in this child. As you can see from this chart, there were vitamin D deficiency along with hyperparathyroidism, along with hypocalciuria being also present in this child. Now, as the child initially presented to us with neurological signs and symptoms, we went for neuroimaging after the stabilization of the child. At first, NCCT brain was done, which interestingly revealed hypodensities in both temporal lobes, left parietal occipital cortex, and right posterior subcortical white matter. So there could be multiple cerebral infarcts present in this case. Next, MRI brain was also done, and the findings corroborated with that of the CT brain findings. MR angiography, 2D ECG were also done in this child, but all of them were within normal limits. So to summarize in brief, it is a case of an infant with right hemiparesis, multiple GTCS, with carpopedal spasm, with hypocalcemia, hypophosphatemia, with vitamin D3 deficiency, with hyperparathyroidism, and with multiple cerebral infarcts. So it could be a case of vitamin D deficiency induced symptomatic hypocalcemia with hypophosphatemia with secondary hyperparathyroidism with multiple cerebral infarcts causing right hemiparesis. Now, to find out the correlation between calcium disorders and acute ischemic stroke in children, thorough review of literature was done. And we found that there were only one case report that depicted the correlation between acute ischemic stroke and primary hyperparathyroidism induced hypercalcemia. That was found, but no case reports of hypocalcemia along with acute ischemic stroke was found, even after thorough review of the literatures. Now the treatment part, the child was started on calcium, oral vitamin D3 supplementation. Gradually the seizures were controlled in this child, the weakness subsided and the general activity was restored in this child. She was discharged 2 weeks later after normalization of both calcium and phosphorus levels. On follow-up, the child is doing well and her activity has been restored to pre-illness level. Serum 25-hydroxyvitamin D3 level has been normalized after 1 month of therapy. No new complications have occurred since discharge. Interestingly, though, the mother of the child was also found to be vitamin D deficient on follow, and she too was started on oral vitamin D3 supplementation. Now, the take-home message from this particular case is that the vitamin D deficiency can present with hypocalcemic seizures very commonly in neonatal and infantile age group. And keeping in mind the high prevalence of vitamin D deficiency in healthy term infants in India and the limitations of routine screening for vitamin D levels in our community, multiple professional bodies have recommended that 400 international units of vitamin D supplementation is to be given daily in infants till 1 year of age. And as maternal vitamin D3 concentration is a good indicator of the status of vitamin D3 in her fetus or newborn, vitamin D deficient pregnant mothers are recommended to receive 600 international units of vitamin D supplementation throughout their entire pregnancy period, even continuing into their child's infancy. Now coming to the second case. A 2-year, 7 months old girl from Jalpaiguri, West Bengal, third born out of a non-consanguineous parentage, presented to us with multiple episodes of convulsions involving all 4 limbs for the last 15 days. Coming to the history of present illness, the convulsions were generalized in nature, involving all 4 limbs. Each episode lasted 1 to 2 minutes. It started 15 days prior to hospitalization. Initially, the seizures were occurring 1 to 2 times per day, but the frequency gradually increased to 10 episodes per day for the last 5 days. The seizure episodes were not associated with uprolling of eyeballs, falling from mouth, or any loss of consciousness. There were no history of any preceding fever, head injury, rash, bleeding, vomiting, loose stools, or any recent vaccination. On probing further, we got to know that the child has been suffering from similar types of events since 1 year of age. Initially, although the seizures used to occur once in every 2 to 3 months, but the frequency and the duration both have increased of late. The child and her family initially sought the help of alternative medicine, but no modern medicine was taken by this child until now. The perinatal history in this child was insignificant, and the child was immunized up to date as per national immunization schedule. As it is very much evident from the chart given along with, you can very well observe that the child is lagging in developmental milestones in all 4 domains, be it gross motor, fine motor, social, and speech. So she is a case of global developmental delay. The family of the child belonged to upper lower class according to the modified Kukuswami scale, and the child is a product of non-consanguineous parentage, as I mentioned earlier, and there were no history of any seizure disorder, brain SOL in the family. The child was exclusively breastfed for first 6 months, and then complementary feeding was initiated. No protein calorie deficit was there. Coming to the clinical examination proper, the child was alert, active, but irritable. The decubitus of choice was supine. There were no facial dysmorphism, no ear discharge, no obvious bony deformities present in this child. No skin vesicles or neurocutaneous markers were seen in this child after careful examination. The vitals involving the pulse, BP, CRT, temperature, respiration, saturation were all within normal limits, and the child was normotensic, as her BP were within 50 to 90th percentile as per her age and length. Coming to the anthropometry part, as it is very much evident from the chart given along with that the child was moderately stunted, but she was not underweight, and she was not wasted either, and her head circumference for her age was within normal limits. Coming to the CNS examination proper, the higher mental functions were the higher mental functions of the child was intact. She was alert, and GCS was 15/15. All cranial nerves examination were all within normal limits. The motor system examination revealed power reduced in the grade of 4/5 in all limbs, and deep tendon reflexes were brisk in nature, although the plantar reflexes were bilaterally flexor in nature. The sensory system examination were all within normal limits, though sensory deficit was present in this child. Meningeal signs and cerebral signs were also absent in this child. The other systems examination such as CVS, respiratory system, GIT and lymphoreticular system examination were all within normal limits. Now to summarize this case, it is a case of a girl child with global developmental delay with moderate stunting who presented to us with recurrent seizure episodes since infancy, and there were no familial history of any seizure disorder. With this particular summary in mind, we are thinking about some differential diagnosis such as it might be a case of any seizure disorder or epilepsy syndrome, or she might be a result of any perinatal insult, and there could be some inborn error of metabolism present in this case also. Now we are proceeding towards relevant investigations to find out the actual pathology. Interestingly, the ABG also revealed hypocalcemia, as ionized calcium level was 0.61 millimole per liter in this child. So this child was also a case of severe symptomatic hypocalcemia. Like the first case, IV calcium gluconate stat dose was also given in this child. After that, the seizure frequency reduced, but it was still occurring. So calcium gluconate maintenance dose as well as loading dose of antiepileptics were given, and we next proceeded to further investigations to determine the etiology. Interestingly, though, the routine investigations in this child revealed hypocalcemia with hyperphosphatemia, unlike the other child who was a case of hypocalcemia with hypophosphatemia. So further investigations were also done to find out the disease pathology. And it revealed hypoparathyroidism along with hypocalciuria being present in this child, as the levels of intact PTH was 7.08 picogram per ml. We also proceeded towards neuroimaging in this child, which revealed bilateral basal gangliar symmetrical calcification in this child being present. MRI brain was done next, which revealed additional features of periventricular leukomalacia. One interesting feature that we got from this case was the symmetrical basal gangliar calcification. And there are spectrum of disorders which can give rise to these particular findings, such as idiopathic causes such as primary familial brain calcification or FAR disease, hypoxic changes, any genetic causes or any infectious causes such as torch infections. But the most common reason, most common cause behind this basal gangliar calcification in pediatric groups was the parathyroid disorders. And the parathyroid profile being deranged in this child was supportive of this particular fact. So to summarize, it is a case of a child with global developmental delay with moderate stunting who presented to us with multiple GTCS in infancy, with symptomatic hypocalcemia, with hyperphosphatemia, with hypoparathyroidism, with bilateral symmetrical basal gangliar calcification. So it could be a case of a primary hypoparathyroidism with symptomatic hypocalcemia with global developmental delay with bilateral basal gangliar calcification. Now, coming to the management part, the child was gradually shifted to oral calcium supplementation from IV maintenance dose once the seizures were controlled. Maintenance dose of antiepileptics were also given. Gradually, serum levels of both calcium and phosphorus got normalized. The child was discharged on oral calcium and antiepileptic drugs. The child is currently doing well in follow-up. She has been seizure-free since the discharge, but we are now planning for genetic testing to find out the exact pathology behind this disease, as hypoparathyroidism in children can either exist as an isolated endocrinopathy or can be attributed to different familial genetic variations secondary to different diseases. Now, a brief overview of the two cases that I have presented. Coming to the first case, it was a case of a developmentally normal child who presented to us with acute symptomatic seizures with focal neurological deficit in the form of right hemiparesis. Investigation revealed severe symptomatic hypocalcemia with hyperparathyroidism along with vitamin D3 deficiency. So it could be a case of secondary hyperparathyroidism along with multiple cerebral infarcts being also present in this case. Whereas the second case, it was a case of a child with global developmental delay and moderately stunting who presented to us with recurrent seizure episodes since infancy, which was also revealed to be a case of severe symptomatic hypocalcemia with hypoparathyroidism. And it could be a case of primary hypoparathyroidism and vitamin D3 levels were normal in this child. The bilateral basal gangliar calcification supports this fact. Now, the take-home message from both of the cases are that the electrolyte abnormalities such as hypocalcemia should be considered with utmost importance when investigating etiologies of seizures in children. Hypocalcemia may be associated with a spectrum of clinical manifestations ranging from few mild symptoms if the hypocalcemia is mild to life-threatening seizures, refractory heart failure, or laryngosspasm. And hypocalcemia in children can occur due to a variety of clinical conditions, but vitamin D deficiency and primary hypoparathyroidism, just like our two cases, were the commonest among all of them. With this message, I am concluding my case. Thank you for providing me with this opportunity.
So may I ask you one question, Pingal?
Yes, sir.
So in the first case, you told that it was due to the hypocalcemia and hyperparathyroidism.
Yes, sir.
So how can we explain the right-sided hemiparesis only?
Sir, actually, the weakness could take place due to the calcium deficiency itself, but actually we could not find any correlation between the acute stroke event and the hypocalcemic event in this child.
It could have been in the both limbs or the both side of the body, but why it was unilateral, only right-sided hemiparesis?
But sir, according to me, the weakness could be explained due to the infarct being present in the left side of the cortex.
Now, you said it is a multiple infarcts throughout the cortex, right, left, both.
But the infarcts were large and more prominent in the left side of the cortex, sir. So that could be the reason behind the presentation of right-sided hemiparesis in this child.
Okay. Okay. Thank you.
Thank you, sir.
So actually we
Yes, Dr. Nupur, if you can elaborate further on Dr. Sapan Rai's question.
Ma'am, actually, we tried to dig up on the literature regarding the association of stroke and calcium disorders. So the one case report which we got was for a 14-year-old boy, and there they had it was because of hypercalcemia resulting in vasospasm and resulting in stroke. But when we went out to find a correlation between hypocalcemia and stroke, we could not actually find any correlation. But yes, we plan to do also a prothrombotic workup for this child as well.
Yes, thank you. And there is one more question from Dr. Mihir Sarkar. What is the pathogenesis of stroke in hypocalcemia? Same thing. So the
I
answer
just
is
want to
probably
ask, what the magnesium level was done in this patient? First patient, magnesium was normal.
Sir, magnesium levels were normal in both of the cases. Magnesium level was also done after the hypocalcemic finding, and they were normal in both of the cases.
Actually, they are both hypocalcemia and hypomagnesemia. They have a correlation with the vascular tone. So the hypertension and the vascular spasm that occurs. So that may be so the stroke is happen in this patient. There are multiple stroke you have said in different sites. So there may be the spasm in different time period in the time frame actually, and later on this is one major vasospasm that can lead to stroke. But also you have to look at the other causes of the stroke. This otherwise the workup may be incomplete, and the patient may land up in the later on in another problem or the stroke in a larger artery or larger brain arterial territory. Then there could be a problem. Yes,
Yes, sir. We are
Thank
planning
you.
for further investigation in this child, and as she's in follow-up.
Yes. Thank you, Dr. Mihir, for throwing some light into this conundrum. We are also still not sure why stroke occurred in this child with hypocalcemia, and very rightly said that she will. We also plan to make her undergo further investigations regarding in the presence of any prothrombotic conditions. And now I would invite Dr. Farooq Ahmed, last but not the least. His presentation will be which came first, the chicken or the egg. Let's see. Dr. Farooq, you can start.
Just a minute, Odumita. Just a minute.
Yes, sir. Yes,
For
sir.
Pringle, because they are the PGTs. He has written a product of consanguineous or unconsanguineous marriage. Please avoid that term product.
Yes.
The child was
Yes.
born of consanguineous or unconsanguineous marriage. Don't
Yes.
credit
It
the
doesn't look
product.
very good.
Please.
Yes. Yes. We are rightly said. Rightly said. Point well taken. Yes.
So
Thank you,
proceed.
sir.
Please proceed.
Yeah.
Please proceed.
Dr. Farooq, you can start, please.
Thank you.
Thank you, everyone. Myself, Dr. Farooq Ahmed, first year resident, Department of Pediatrics, North Bengal Medical College and Hospital. Today, I got an opportunity to present an interesting case. The title, which came first, the egg or chicken, and the title will be exactly relevant, and we will understand the relevance at the end of our discussion. A 7-year-old girl with history of documented fever for last 8 months, 102 to 103 degree Fahrenheit, twice daily, relieved by medication, not associated with chills or sweating, well in the interfebrile period. 2 instances of hospital admission in the last 8 months, associated with failure to weight gain, no history of joint pain, repeated airway infection, pain, or any other localizing sign. No contact history of tuberculosis was present. In this episode, fever for last 2 weeks, high grade, intermittent, relieved by medication, not associated with chill or rigor, rash or joint pain, painless swelling around the neck, which is insidious in onset, gradually progressive, associated with weakness, easy fatigue, and decreased appetite for last 2 weeks. Vaccination is up to date according to the NIS, including the PCV13 and PSV23. On examination, the patient doesn't look toxic. Pallor is present, but no cyanosis, icterus, or clapping. Lymph node examination reveals bilateral submandibular, upper and middle jugular lymph nodes are palpable with size 2 to 3 centimeter. Lymph nodes are non-tender, firm in consistency, non-matted, no fixation to the underlying structure or skin, no sinuses are present. No bone tenderness, liver or spleen are not palpable, no oral ulcer, rash or joint swelling was present. This is a picture of the patient that shows that there is bilateral submandibular lymph nodes are enlarged with upper and middle jugular lymph nodes bilaterally are enlarged. With this history and examination, we had our differentials in our mind with long-standing fever, lymphadenopathy, failure to weight gain, such as tuberculosis, lymphoma, immunodeficiency, autoinflammatory, persistent viral infections, and SGIA. With this, as I stated earlier, that the patient was suffering for last 8 months. So a battery of investigation has been performed outside. Some of the relevant investigation have been collected and shown in this slide. These show that there is persistent low hemoglobin level in this child. With CBR done twice at interval, they were both the occasion they were negative. HIV was excluded 2 occasions. No organism was isolated during the febrile phase with the blood culture, and ANA profile was done and it was negative. The investigation performed in our hospital, it shows CBC hemoglobin was 7.4 gram per DL, which is significantly low. TLC is 7,100, which is within normal limit. Platelet within normal limit. CRP 18.4 mg per DL. ESR is 70 mm in first hour. The CRP and ESR is significantly high. LFT and RFT was normal. Blood and urine culture was no growth. Chest X-ray done, and it's shown in this slide that there is significant bilateral hilar enlargement, hilar opacity is visualized. And some infections are ruled out, such as scrap typhus was negative, dengue negative, MPTA negative, sputum CBNAT was no FB was detected. Immunoglobulin profile was seen, they are within normal limits. As the child was suffering for last 8 months, and we have our accessible lymph nodes was present, so we directly perform the lymph node biopsy, and the biopsy report shows distorted architecture with wide areas of necrosis containing plasmacytoids, dendritic cells, histocytes with lymphocytes suggestive of necrotizing lymphadenitis, that is Kikuchi disease. Some points regarding Kikuchi disease. It is also known as histiocytic necrotizing lymphadenitis. It is a rare idiopathic, generally self-limiting disease affecting the young females, characterized by fever, cervical, or sometimes mediastinal lymphadenopathy. The exact pathology is not understood, and the diagnosis is histological. For non-self-limiting, severe, or recurrent cases, a short course of steroid has been recommended. So as I stated earlier, that it is a rare disease. So going to the literature for the treatment, we found that for the fever and pain, some non-steroidal anti-inflammatory drugs may be recommended, and in recurrent cases, steroid can be used. So based on this literature, we started prednisolone 2 mg per kg with clinical improvement was achieved, and the patient was discharged on the tapering dose of the steroid. But the story doesn't end here. After the 6 week, the patient was discharged with a stable condition, but after the 6 weeks, she was presented to us in the emergency with high grades of fever, severe respiratory distress. On examination, tachypnea, respiratory rate was 50 per minute, heart rate 120 per minute, saturation 93 on 10 liters of oxygen with NRBM, bilateral crepitations, tender lymphadenopathy, and no organomegaly. Other investigation shows CRP markedly increased, CBC 8.4 gram per DL, significantly low, TLC 14,000, platelet 1 lakh, RFT and renal function was, liver function was normal. And these are the, this is the X-ray, and this time this show diffuse non-homogeneous opacity bilaterally along with mediastinal lymphadenopathy. Comparing with the previous X-ray, this is the previous X-ray and this is the recent X-ray. And CBNAS recent, blood culture no growth, urine culture no growth. And based on this X-ray, we perform the HRCT thorax. It shows miliary shadows and cavitary lesions with consolidations with lymphadenopathy, which is highly suggestive of tuberculosis. Again, going to the literature, we found that in India, whilst tuberculosis is endemic, and we found that the tuberculosis can also mimic as a Kikuchi disease. There is some case report with Kikuchi disease, and this time the TBA CBNAT was ARP was detected. And considering it to be a microbiologically diagnosed pulmonary TB, she was started on ATT and the marked clinical improvement was achieved, and the other antibiotic and antifungus was gradually tapered. Though the story ends happily, the question remains, as it is a case of Kikuchi disease from the beginning. After giving steroid, she became immunosuppressed and became tubercular positive, or it is a case of tuberculosis from the beginning. Going after giving the steroid, the TB flares up. Thank you.
Thank you, Dr. Farooq. Thank you, Dr. Farooq. Actually, here the hen and the chicken and the egg are the tuberculosis and Kikuchi. Though with all possible means, before starting steroids after the histological diagnosis of Kikuchi Fujimoto disease, knowing fully well the steroids might flare up the tuberculosis, with all possible, including CBNAT, X-ray, everything was negative and there was no trace of tuberculosis in her. But when she presented to us again with deterioration in her condition, then at that time there was a change in her X-ray, and then CBNAT was also positive. So we now face a dilemma that did we miss tuberculosis in the initially and started steroid without giving anti-tubercular drugs, or tuberculosis was not there in the beginning, it after starting steroids for Kikuchi disease tuberculosis. So question, I don't know, we don't yet have that answer. We are we have searched literature. There are some associations between TB and Kikuchi, but in those associations, TB things like TB, the investigations were in favor of TB from beginning, but in our case, there was no investigations led us to think of TB in the beginning. So with this, I think we are in a dilemma that what more could we have done?
Actually, if you see carefully the hematological parameter, this child had low hemoglobin from the onset, 7.2 or something. Hello.
Yes, sir.
Hello.
Yes, sir. Yes, sir.
So, and again, what he has said during the presentation in the first X-ray, there is not hilar lymphadenopathy. It was a mediastinal lymphadenopathy. So at that time, our antenna should be raised. Because in Kikuchi also you get the necrotizing lymphadenitis, and in tuberculosis is also a necrotizing,
Yes,
just
sir.
like the
Yes.
the adenovirus we have seen. We have got the
Yes.
example. So initially, I think starting this steroid may have augmented the process of the tuberculosis. So, and Kikuchi, because the pathologist has given you the report, and he has seen the lymph node over there. And then he said there is a necrosis. So by permutation and combination, he has given a diagnosis of suspected Kikuchi. So he is right on this way, but we must, in our country, we must
Yes,
think
sir.
about the
Yes,
tuberculosis.
sir. But the question remains without any diagnostic confirmations.
Actually, Dr.
What-
Madhumita,
Yes, sir. Yes, ma'am. Yes, ma'am. Yes, Kalpana
Another
ma'am,
thing is
you
that
are welcome. You are welcome. And actually, very frankly, I asked him to present this case to just take all your opinion that where we should have, in spite of CBNAT negative, MAN2 negative, we didn't, and it was pathologist diagnosis was Kikuchi. Kikuchi as such does not need any treatment. But as she was suffering for last 9 months, she was having fever, she was having distress. So we thought of giving her a short course of steroid. So did that short course of steroid aggravate her condition or making her immunosuppressed and then she got the TB infection? We don't know.
But in Kikuchi, there won't be so much low hemoglobin level. So we have seen it is a 7.4.
8.6 hemoglobin was
Second time. So when
yes, second
she was
time
admitted second time, in the first time it
second
was
time
7.4.
yes sir, yes sir,
And
but
another, Dr. Rupa বিশ্বাস has posted it is not a miliary shadows. Actually, the miliary shadows may be from 3 millimeter to 8 millimeter. And in the Crofton textbook of pulmonology, they have said from 2 to 20 millimeter. So miliary shadows may have a different size as such. So it was a
yes,
case
sir.
of miliary shadows.
Yes, sir. And the CT scan picture first. Initially, we didn't do any CT scan, but after when she presented for the second time, the CT picture was more like miliary TB. So
Anyway, so it was excellent presentation by all of you. And in fact,
hello.
what we have planned. Oh, our president is there. Oh, please.
yes, ma'am.
Proceed.
Yeah, and as my experience says, Kikuchi is usually misdiagnosed with the tuberculosis, and it is said even in the books it is written. Usually they get the anti-tubercular drugs from the pediatrician. Then there is no improvement. Then it is diagnosed in the Kikuchi. But in your case, it's just the reverse one. So first it's a Kikuchi, and you give the steroid, and then flare up with the tuberculosis. So there, where some focus might be there in the focus in the tuberculosis there from the pre-existing, and it was not more than 6 weeks. So MT was negative because you may get them MT negative if it is an incubation period. So then LTBI yet to be developed. And so MAN2 could be negative, and that could be there's a focus in the tuberculosis in the body. As soon as you get the steroid, that flared up. That could be the one possible explanation in this
Yes,
particular
ma'am.
case. That is
Yes,
what I
ma'am.
wanted
Yes,
to
ma'am.
say. Thank you.
Yes, ma'am. That could be one of the possibilities.
So thank you again for the nice cases. In fact, our intention was to reach to the periphery, and our purpose is already served. And I think the students are showcasing their talents. But I'm really overwhelmed by the type of cases they have shown, and at least 2 boys has presented the 2 cases side by side. And that is a newer approach. So I must thank the mentors. Dr. Nupur Bajpayee and other for this excellent presentation. So I will request President Dr. Kalpana Datta to conclude the session.
Okay, thank you, Dr. Shapun Roy, for giving me the opportunity. Actually, I'm very sorry I could not join from beginning, as I had today and Thursday. Usually, I have a HIV meeting, and we had a lots of patients today, and so I finished my round just now, and I just attended the last case only. But it was very fantastically presented and very nicely executed. Thank you, Madhumita, for your guidance and all the mentors who are there. I'm really thankful that all of you making us proud, and the West Bengal Academic of Pediatrics is improving leaps and bounds. So with all your help and all, that's all I can say. And thank you for giving me. Thank you all.
Thank you all. And again, a big thank you to West Bengal Academy of Pediatrics for giving us this opportunity so that we don't feel deprived staying at the periphery. Our PGTs are also very happy that they have got this opportunity. Thanks, sincere gratitude to you all. Thank you.
So see you soon on the next month before we reach to some other place. So bye-bye.